Well, good morning. Welcome to the Anschutz Health Sciences building. We'll be here this week and next. Both times we'll be meeting with Dr. Patrick Fehling, who's our speaker today and next week. Dr. Fehling is a practicing psychiatrist. He's associate professor in the Department of Psychiatry. He spends half his time in private practice and half his time taking care of patients at Cedar. And so today he'll be speaking with us about alcohol use disorder. And then next week we'll be talking about optimal management of stimulants in patients with ADHD. Dr. Fehling went to med school at University of Wisconsin-Madison, and then he did residency here in psychiatry and then a fellowship in addiction psychiatry. So an expert on these topics, and we're grateful to have him here. So thanks for joining us.
Sure, Brandon, thank you. Okay. No microphone, I can just speak openly?
I think there was a phone.
Yeah. Okay, wonderful. Let me know if it's not. So I'm happy to be here. So I'm Pat Fehling. I think the last time I presented for GIM Grand Rounds was maybe 2018, 2017 at Denver Hospice. I guess that's when Grand Rounds was still in that area. Today, I'm really going to lean into kind of some more abstract topics in the realm of drinking. And I'm going to talk a little bit about some of the research and some of the, I guess, articles that I liked, that I thought were interesting. And maybe one of the main take-home messages for anybody is to not be afraid with in-depth dialogues with your patients about drinking, like drinking patterns, how people actually drink, and then also to pivot that into real commitments. What are we trying to do? Okay, so we look at alcohol use disorder or alcoholism as a spectrum condition. And this is kind of the bread and butter of what we have at Cedar. So Cedar is a residential care center. I've been at Cedar for about 12 years. And it's about 85% of the folks we have alcoholism, have alcohol use disorder. Now, Cedar and most dedicated specialty treatments, right or wrong, have been abstinence models. So that basically means we're trying to help people quit drinking. And it's very important for you to have that in your toolbox in terms of the whole world of if you're really aiming that way. But it's also important to have some idea about a middle ground. Maybe the $1 million question for folks who really have a drinking problem is, can you still drink, but just drink less? Can you cut back your drinking? I'm actually going to talk about that. That's actually been more progressive research has actually started looking at some of these kinds of things in terms of can we do tailored recommendations for patients? And I'm going to talk about a few other things as well. So we think of alcohol use disorder as spectrum health condition. Understanding abstinence versus moderation initiatives, and having a sense of both of these in your toolbox and working with the patients. And then also understanding, I'm actually not going to focus too much on the world of MAT, which is the med-assisted treatment. We think of topics of like naltrexone, antabuse, gabapentin. This is kind of the toolbox that we very heavily use at Cedar. I'm going to talk about it at the end. It is important to know that these meds have utility if you're aiming for either abstinence approaches or moderation approaches. Okay? But you have to understand what you're trying to do to be able to build kind of a better strategy with your patients. So some of the questions, I'm just kind of listing them as I kind of talk through this. Non-abstinent recovery. What does this mean? How to work with it, clinical practice. Clinical reductions in alcohol, like helping somebody actually reduce their drinking. What does that actually mean? I'll skip over some stuff. I'm really going to explain this. Some of the research argues that if you're trying to help somebody who is in a concerning territory with their relationship with alcohol, and they would like to cut back their drinking, maybe the take-home message is be aggressive, which is they may have to make a sizable reduction in their drinking to be any meaningful thing at all, instead of just a mild reduction or like a progress, not perfection. The argument was, and I'll talk about the research study that looked at that. And then at the end, I'll talk even a little bit about, this is very big from a primary care angle on the question mark of safe alcohol use. And a lot of times in clinics, we really, we stick to some of the old CDC guidelines, really, that safe boundaries for a man is on average 14 drinks a week, safe for a woman is on average 7 drinks a week. There's some newer data that those numbers may be a little bit generous. And some of this, and I'll talk about that a little bit at the end. Okay. So this diagram, I've drawn this diagram countless times in my office with patients. So the way it works is I have somebody who schedules with me, or their spouse asks them to schedule with me. And we sit down, and the topic is we have to look at their drink in terms of really how it's going. And I'll kind of draw this out. I'll say that you have on the left side, you have kind of normal or safe drinking. And I'm listing with this, once again, the average 14, average 7. So this is the normal range is, for this purpose, I'm saying the CDC guideline normal range. We've got at-risk drinking, which basically means greater than normal. Problematic drinking is where we introduced some sort of harm, so some sort of consequence. So that could be a DUI offense, it could be marital conflicts, it could be lost jobs, it could be maybe liver inflammation in isolation, kind of thing. And then we have a very important line in the sand, which we cross into alcohol use disorder. This is stratified as either mild, moderate, or severe. And some of you may remember, we have 11 symptoms of alcohol use disorder, but it didn't used to be that way. It actually used to be this kind of mashup of what's called alcohol abuse and then alcohol dependence. The idea was that alcohol abuse was more maybe the wilder drinker who was drinking and getting into fights in bars, or they were just, I don't know, causing some sort of issues. And the alcohol dependent person was the maintaining, withdrawal-based person who would have seizures, who would have to go through a fifth of liquor every day. And it was kind of confusing. Are you an alcohol abuser or an alcohol dependent kind of thing? So this changed I think this changed like maybe 15 years ago, in which they kind of combined them. And they took all the exact same symptoms, mashed them up together, and they called it alcohol use disorder. Now that is true. Those same 11 symptoms are for any addictive disorder. Right? Some of them are a little bit redundant. So for our purposes, I really break it down, including for patients, really to these big 5, that we care about these things: tolerance, withdrawal, loss of control, continued drinking amidst harm or decline, like a functional decline, and then cravings. And cravings was, that was an addition of the kind of the new framework of this, and appreciating how strong cravings really are for people who have a real alcohol problem. AA, for the world of Alcoholics Anonymous, is going to say that the symptom on this list that's actually the most important is actually number 3, is actually loss of control. And that connects a little bit with what I'm talking about today on this million-dollar question. If somebody has alcohol use disorder, they have a hard time controlling their drinking. Helping them cut back their drinking may be a failure. So phrasing, kind of, AA is very big about, oftentimes comedy or joke-based phrasing, but they'll say, anybody dealing with drinking, 1,000 is not enough and 1 is too many. So it really speaks to this idea of the switch is either on or it's off. People are either in their drinking or they're abstaining. One thing I will, let me back up for a second with this. It's interesting when I mentioned, when I draw this out with patients who are talking about this for the first time, I'm always very curious, and I ask them after I draw this, where do you place yourself? Like, where are you on this curve? Most people place themselves to the right to the left of the line. Okay. they're no dummies. They kind of know that they're in the office. They're like, okay, so to say I'm in normal range would be very realistic. They kind of say, well, I have a problem. I know I have a problem. On the left side of the line, it is implied that they can still have a relationship with alcohol in their life, just less. Whereas if we get to on the right side of the line, we start talking about, do they need to fully put it down? Okay. And that can be, I think for some people who have a real problem and are kind of, I don't know, coming to grips with this, that's almost an existential crisis for some of these folks. Now this gets really complicated when we're talking about alcohol use disorder mild. Okay. I've seen that go both ways. If you're in, just for the numbers here, mild is 2 to 3 symptoms of the 11, moderate's 4 to 5, and then severe is 6+. So if you're in mild, could you keep a relationship with alcohol, just less of a relationship? But I think if you're in moderate or severe land, we need to start talking about a full stop as really the only way, once again, connected to the topic of control. Okay, these are some of the kind of more progressive articles that I'm gonna kind of link a little bit to what I'm talking about today on this topic. Can individuals with alcohol use disorder sustain non-abstinent recovery? Expanding the continuum of substance use disorder treatment, non-abstinence approaches, the stability of drinking reductions, long-term functioning, and the association between daily alcohol intake and risk of all-cause mortality. So we think of abstinence, I mean, this is kind of a goal. It's always almost a requirement for anybody in the land of recovery, but this is very important. And this is once again connecting to things like Alcoholics Anonymous and how people will say it. They'll say that abstinence is no longer drinking alcohol, that is necessary for recovery, but it is by no means sufficient. And it basically means recovery is more about a frame of mind. It's that somebody has stopped drinking and they've started kind of working on the wreckage, if you will. And we think of people like making amends in their life, or starting to work on their relationship, starting to really make very sizable changes about this last 10 years and everything that's happened. AA will use a little bit of a pejorative phrase with patients that some of you may have heard in the office or things, and the topic of the dry drunk. So the dry drunk is a phrasing that basically will say you are abstaining from alcohol, but you are very clearly not a happy camper to really pretty much everybody in your life. Okay, difficult, irritable, frustrated, but you are abstaining. Or would somebody say that you're really in recovery? No, you're not. You are sober, but not really making changes. I've actually seen with patients countless times, especially in relationships or marriages, things, where the loved one basically says, you know, you were actually better to deal with when you were back in your drinking. Maybe you should actually just go back to that. Okay, so some of this is kind of orchestrating this unconscious long game to get people back to their drinking, because they're just so frustrated, they're just so difficult to deal with because they don't have alcohol, and then they basically say, fine, just go back into the basement and go back to your drinking kind of thing. We would say that that person has not really crossed some of these more abstract milestones of recovery. But the topic of loss of control, once again, is very important for this. Cedar included, where I work at, we have historically all been abstinence-only strategies. And there's maybe some data that that's not correct. There should actually be some room for moderation approaches to be able to navigate this with some patients. Okay. I thought that this article was very interesting. This is Witkowitz, just a few years ago. They looked at people they kind of broke patients who received specialty addiction treatment into high functioning and low functioning. And then they tracked them at the 3-year mark and the 10-year mark. What was interesting with this is the take home was that the high functioning, whether or not they were either drinking or in recovery, were always functioning higher than the low functioning. So the high functioning people who were still relapsing were still functioning higher than the lower functioning folks who were abstaining. I just thought that was kind of interesting. We thought initially that you would pretty much lose everything in your life if you had, no matter how functional you were, if you had active alcohol use. But that didn't seem to be the case. Yeah, go ahead.
What were the criteria defining low functioning?
That was it's some sort of a rate. It was a rating scale. There's a few rating scales that they're using in these, and I'm not sure exactly which one it was. But this also integrates one of, if you look at a lot of the research, they connect back to this a little bit dated program called Project Match. And Project Match was this like multi-site huge thing. So a lot of research studies, they take the findings of Project Match and they follow it forward. So that was one of these as well. But in very simple terms, it's things like employment, housing stability, a degree of health utilization, criminal activity, things like that. Okay. I use this topic of goal-aligned treatment. I think that's really big for if any sort of take-home messages for anybody kind of participating today. Having thorough conversations with your patient about how they envision their relationship with alcohol. Right? So, I mean, it's like we've established, or you're walking through with them, it looks like you're in this land of a problem. You have some sort of, you're across the line of a problem. How do you envision actually going about it? And let's start. Do you think, are you pursuing abstaining from alcohol, or are you trying to drink less? Now, just because somebody wants it to be doesn't mean it'll necessarily be. Right? That is one of the goals of sticking with people over time, to kind of test, almost like that I'll tell patients and I'll say, this is not my experiment. You're the one conducting an experiment. Can you keep alcohol in your life? I hear you that you want to. We could monitor that, okay? But I can't promise that you're going to be able to succeed with your experiment. Okay? And at the end of the day, we have to be really pretty honest. One thing I will say that's a little bit different, there's the whole, in addiction care, there's the whole world of motivational interview, motivational approaches. Interestingly enough, I think a lot of specialty guys, or really in this care, are a little bit more directive, like in terms of, I think this is what it's going to have to take, kind of thing, instead of how do you want to proceed with this. Sometimes care is a little bit too open-ended, or they emphasize this topic of roll with resistance, I guess. A very clear example for that you may know or maybe don't know is with tobacco cessation. If you say to your patients, it's time to quit, it's time to quit tobacco, you actually double quit rates. Sometimes I feel like we get lulled into a highly consumer-focused approach in a way where the person's like, you don't want to quit, no problem, that's fine, we'll revisit this. That's this idea, this spirit of what we call rolling with resistance, which always has a play, because we're not trying to get into power struggles with patients or badger them in any way. But at the same time, directive approaches do seem to land from somebody's provider. They feel that those are probably it's either the number one or number two reported reason that somebody quit tobacco was the doctor recommended it. Okay. There's this a theme here of harm reduction. Harm reduction is talked about a lot in opioid care. We think of like Narcan access, needle exchanges, all different things that we're going to do. There's no clear, the idea of harm reduction connected to alcohol use. This is our, I guess, professional experience devising this. When I like driving restrictions, lab monitoring. I have some folks who they're just not done with drinking, but we might put an interlock device in their car such that they will not be able to, if they can still go in and out of their drinking, but they just cannot drive their car. That's a harm reduction initiative. A lot of people say what Harm reduction, by definition, is you're trying to limit the worst of the consequences, regardless of how much substance use is still going on. So the classic one is somebody is still using opioids. We just want to prevent HIV transmission, or we want to prevent overdose deaths, not going after the volume of heroin or fentanyl really at all. And I think it would be the same philosophy if you want to use harm reduction approaches with drinking instead of pure moderation goals. Okay. So it's maybe my take home with that is it's important to differentiate moderation versus harm reduction. Okay. In terms of the topic of MAT implementation, naltrexone is a useful tool. In simple, I would say. I think naltrexone, the data supports it being useful for abstainers. It's probably best for people who are abstaining from alcohol, but useful for people who are trying to moderate their drinking. Right? But you have to be honest with patients on how they do, I guess, I have had plenty of patients who they were knee-deep in their patterns of drinking. And when I say that, they're drinking fifths a day. I mean, so they're going through 17 drinks a day. They meet with a primary care doctor, and their doctor says, we should talk about naltrexone. The doctor is doing a good job of saying that that's a value-added approach. But I have the patients, very often I'll hear them say, it didn't do anything. It didn't help me. Right? So in treatment, I would say that's fine, but we are going to revisit it. Okay. What I mean by that is I think naltrexone is maybe not, it doesn't have quite the effect size to break people out of hardcore alcoholic drinking. And so just because sometimes the patients, they feel like it got soured in their mind, as if, well, this is not really going to be a useful tool, it didn't do anything. I think it may, if we've helped you abstain and then to keep you abstinent from alcohol. I think it's also important, and I'll talk about this a little bit on the idea of higher levels of care in terms of based on functioning. This is kind of my world. Okay? This is what I do professionally, navigating these levels of care. My career itself, half-time, I'm on the top. I'm in level 4 care. Half-time, I'm on the bottom. So it's in standard outpatient care. Those approaches are very different, and the philosophies of really what we're trying to do is different. But the biggest component is motivational. And what I mean by that is the folks we have in outpatient care who are seeing a specialty provider for addiction purposes, ideally want to be there. It's important for them. They're working towards a goal. That's not always the case on the top level of care. Usually people that we have in Cedar and residential treatment are there it's a crisis situation, or maybe a legal situation or a housing situation. It is important for me to comment a little bit on, for anybody who's been at the university for a very long time, you may remember of the days of Cedar long ago, where Cedar was much more designed to be almost like a Betty Ford Center in Colorado. It was that when I was first at Cedar, it was only out of pocket. People would essentially pay upfront for 30 days of care. It's very classical rehab. The second iteration of Cedar, about maybe 5 to 7 years ago, was when we started navigating a lot with private insurance. And in these last 4 to 5 years, the entire world of what we do is Medicaid. So it's about 3/4 of the folks that we have at Cedar have Medicaid or public insurance. That's good to know. So I'm putting on the table for anybody here and anybody on this call, if you say, I can't refer my patients to Cedar because they don't have any money, you have to talk to me. It means you're not listening. If your patient has Medicaid, Cedar works incredibly well with Medicaid. Most people are getting between 2 to 3 weeks of residential time. And then we're actually stepping them down into, we call it some of these level 3 care options. This is a giant puzzle to solve. This is the puzzle of the multiple years at Cedar of trying to solve this public insurance hybrid of how much private insurance, how much public insurance that we're dealing with. Okay, but just so you know, On the residential, like today, this morning, we have 30 residential patients at Cedar. We can go up to about 50. It's kind of max. And then the outpatient curriculum, it's like a couple thousand patients who are managed in outpatient Cedar care. And then we break that in half in terms of how many people are in the opioid pathway compared to other. The opioid initiatives that Cedar has are second to none, including including like injectable Suboxone. We have like these very high-end options called Sublocade, Vivitrol. Level 2 care, I'm not going to talk about too much of that. That's a group therapy approach. We call that IOP. So this is the kind of the hierarchy of what we really navigate for anybody who's in kind of specialty addiction care. Should I pause? I can actually pause for a moment. Are there any questions in the chat or anything about any of this?
How does the intake for residential service, like what's involved? I mean, do we just drop a referral and you guys do the rest, or what's involved in getting a patient into residential?
So they have to do it doesn't require a referral. The patient does have to do called a level of care assessment, which sometimes is difficult because if the person is in very intense active drinking, their ability to engage in an assessment, basically it starts with a phone call and then it's an in-person assessment, which they have to make sure that their benefits are all up and running and things like that.
So does the patient call Cedar, or is that how?
Yes. Patient and the contact, it's 720-848-3000. And we actually can admit 7 days a week. So I think for the most part, if you have an interested patient, even moderately interested, and especially if they have an immediate family member that helps them out, that is priceless. I'm gonna tell you, if you have somebody and their spouse or their parent or their grown child or something like that, it's like dad needs to go to treatment and that person is engaged in the process, that is usually a deal maker in terms of them succeeding or getting something really going. We can usually admit somebody within a day or a couple days. So this is not like a multi-week wait or something like that. It is pretty fast workflow to get people in. There are some instances where well, it might be difficult or not appropriate. The biggest one that we've actually seen recently that we're talking more about is cognitive limitations. There's actually not wonderful options for somebody if they're starting to show signs of any sort of a dementia process. We have a really hard time of trying to help them out and get them stabilized. Oh, what else? Oh, go ahead.
Yeah, a little off topic, but do you have any thoughts on how the introduction of beer and wine into grocery stores is affecting drinking rates or difficulties?
Yeah, so it's gone up. The big take-home data in the country has been the escalation of drinking patterns with women. And so now that was a shift that happened post-pandemic. Prior to that, the volume consumed was more maybe a 2-to-1 ratio of men to women, but the women are catching up by a wide margin. The majority, I believe this is the case, but somebody could fact check this. I believe the majority of new livers that we're doing are now weighted towards women. And some of that is that women have a higher rate. It has to do with percentage of fluid and body fat and things like that in terms of progression to liver disease. So severe liver disease. So now it used to be that the livers were pretty even of men to women, but that's because the men were drinking harder. Now with this catch up, now that's at least what we're seeing. A lot of age 35 to 50 women with liver disease, very severe liver failure. That's caused by drinking.
Dr. Fehling, there's a comment in the chat, might be worth expounding upon, from Dr. Neeb. It says, if you put the addiction medicine referral into Epic, Cedar will call the patient, but often the patient doesn't answer and will say they were not called. The patient can also call directly and speak to someone in admissions. And then the other is that Medicare is very challenging to get resident treatment covered. And then there's another comment here, question, is there an option for people that do not have any insurance, for example, sliding scale? I don't know if you can comment on the issue of putting in the referral in Epic. I don't know if you type in Cedar, does that work, or does it have to be this addiction medicine referral?
So the only thing, I am not sure about that. I know that Cedar itself is not Cedar, it's actually CR Care. So you could actually look at, that's a little bit of a pro tip, I guess. It's SEA space letter R space care. That was put into our medical record to increase a little bit of the confidentiality of it all, such that of providers in the system, if you saw somebody's medical chart, or if you knew that they were hospitalized right now, that you may know, or if you had some knowledge of this, that they were getting specialty, or they met the criteria for a substance use disorder. But I believe the workflow is still all under that. So CR Care. What was the second question again?
So Medicaid sounds like that works pretty well, but Medicare is.
Oh, yeah, Medicare does not. So we do not take Medicare, and sliding scale fee for service. I don't believe so. There was, and the reason we used to have, that was actually more of the days of 10 years ago, where everything was out of pocket, and then there was more of a philanthropy endowment for scholarships. So now, as we've pivoted to much more public insurance, there's nowhere near the degree of fundraising and scholarship support for that.
I have one other question. So many of us take care of physician colleagues, and so this came up for me where someone was having a problem and needed urgent referral, and I got tangled up in whether they needed to like just go straight to Cedar versus like getting CPHP involved. Do you have any advice on?
Oh, so that's actually a very good question. So they can go direct to Cedar. They CPHP is a intermediary. Okay, so CPHP is for anybody who knows how this all works, they're a dual role entity that will conduct an evaluation of somebody, we'll say a flagged physician, but it could either be a self-report or flagged. They will then make a recommendation in terms of where they're going to refer the patients. I'm not going to get too far down this, but they have been exceptionally referring folks out of state more so than in state. So now if you are, especially if you're a physician or a provider who has alcoholism or another addictive disorder and has some experience with it, like you've used treatment before, you've kind of, especially if you've used AA before, you've had some sort of a connection, like you kind of embrace that you're in a relapse, but you're interested in resuming, like rebuilding or restoring your recovery, then I would pursue working with Cedar something direct, and then talk about either reopening a case with CPHP or kind of going forward with that. For everybody, when you where this really, I guess the rubber meets the road, I guess, is in your medical license. So when you renew your medical license, there is a checkbox that says, have you been treated for an addictive disorder? There's one box of, are you under the current struggle with drinking and drug use? But there's another one, have you been treated for an addictive disorder in the past, or are you currently treated for an addictive disorder? Then there is a little called a safe haven clause that says you can legally check no if you are under the umbrella of CPHP. Okay, so that we call that the safe haven clause. So if you are dealing with this, especially when it's time to renew your license, the recommendation is that you are known to CPHP. And working with Cedar, we can then help you do that. They will basically, CPHP doesn't deliver treatment. They're just a hub. It's just like almost like a monitoring hub. And then they will say, they'll put you on a multi-year contract. I believe it's usually a 5-year contract in which you have to do some sort of drug screen testing or random monitoring or accountability testing. They usually will recommend that you participate in a a very hyper-specialized AA group process we call caduceus, which is kind of like AA just for physicians and nurses and psychologists and things. And if you do that, and then they meet with you quarterly to say, are you following through? And so it's really about treatment retention and follow through. Okay. Oh, what else? Other questions? Okay. All right. I think I might skip this a little bit. I mean, this any patient that we have, we walk through these 6 criteria to kind of rate them, if you will, of disease severity. So we call this as this is the American Society of Addiction Medicine patient placement criteria: detox, medical, psychiatric, level of motivation, relapse potential, and environment. And we're doing this regularly. We're also doing this for insurance purposes. This is their rubric as well in terms of authorizing covered care. We're talking about building an overall recovery plan for any patient. I've designed this, and I kind of work on this over the years. I call this my recovery layout. And we got the concept of psychiatric care and MAT. So that's MAT specifically, things like naltrexone, antabuse. We've got the continuum of care, which is treatment. And then I'm already alluding to the element or the benefit of peer support, and that is people that are using things like 12-step. It is important to know a lot of people, we've had a very good experience with some of the non-12-step options for patients. There's a newer program that's called Recovery Dharma that has a lot of a bolder element that seems to draw more from kind of Buddhist philosophy or Eastern medicine that people have really liked. They thought it has been really positive. There's some peer support programs that involve heavily spiritual elements. There's like the Celebrate program, or there's the LDS program, or there's some that are very cognitive. They're really not about any sort of faith or spiritual angle. There's a fair amount of spiritual language in 12-step. And so when patients say, oh, that doesn't speak to me, I'll usually say, no problem. That's fine. But they will then, I'll put them to the test if I say, well, what would you like to do instead? And if they say, well, I'm too busy these days, then I might play my BS card on the table at some point. Okay, because you're going to need to do something to really help yourself build a good recovery plan. Okay. I think that this was really interesting. This is the article of talking about, can people reduce their drinking and stay reduced? Okay. And so how do you offer guidance with patients? Now, this is getting back to the patients who want to keep drinking. They want to reach some sort of a moderate goal. How to really guide them? And once again, I guess the take home with this was make a commitment to a sizable reduction instead of just like a small reduction. It's the data of this show that small reductions usually translate to no reductions. I skipped over this, but even just remembering what our standard drink equivalence is useful for patients. And this is a little bit of a pro tip, if you will. I ask patients not just like how much you drink, I ask them like how they buy their alcohol. Like what are they actually purchasing? Are they buying, are they going through bottles of wine? Because a bottle of wine has about 5 drinks in it. Are they going through fifths? So once again, so a fifth is a 750. That's a very common increment of the folks we have in residential care. So that's about 16, 17 drinks every day. It is not uncommon for us to have folks who are going through handles. So a handle is a 1.75. So there's 39 drinks in a handle. Okay. This is high octane alcohol consumption. Okay. Sometimes we forget this, where they're like, oh, are you a heavy drinker or something like that? No, this is the real deal of how much real alcohol people go through. Real in depth, I'll ask people of, we are in Denver and people that love their IPAs. Is that 7.1% alcohol, 7.7% alcohol? Those are like 1.5 beers. I mean, there's some beers that are essentially double beers. So it's important to have some sense of this. Like if they're going through 3 beers, but are they actually going through 5 or actually going through 6? We use this to stratify where you're really at in terms of are you at more of a mild, medium, or severe. I like this. This is the World Health Organization risk levels, and they kind of stratified people as either low risk drinking, medium, high, and very high. So think of this as per day. So low risk is 0 to 3 drinks, medium 3 to 4, high risk 4 to 7, very high 7 up. Okay. So the take home with this is that they really recommended doing 2 drops. Okay, if you wanted, so basically that meant if you have somebody who you think is in very high risk land, your goal is to encourage them to drop all the way down to medium risk. Right? So it's basically that if you're drinking 7 or more drinks, the person our really boundary for you is 3 drinks. Right? If you have somebody who is drinking 4 to 7 drinks, their goal is 0 to 3. Right? So basically, a classic one is you have somebody, when you really start talking to them, it looks like they're going through about a bottle of wine a night. If you want to keep drinking, your boundary might be going from a bottle of wine a night to a glass of wine a night. Then you actually, these conversations can go really very well. That's one thing I will say. Most folks who struggle with drinking, I know there's a lot of cultural elements of things like shame and stigma, and I don't know, maybe it's stylistically of people who do a lot of addiction care. We're pretty positive and talking. I mean, I know a lot of patients and they're drinking, they're a little bit wild, they're a little bit risk-taking. I've personally found that they're not super afraid to talk about in depth, like how am I actually drinking? What do I actually love? I ask people what brands they're buying. I ask people if they're buying shooters or not shooters or the airplane bottles of alcohol. That's a very important screening question as well, because usually when people are in the land of buying shooters of Fireball and things like that, they're doing that to try to rein in control. It's because, and there's a lot of patients, and they'll actually tell you, like, I can't buy pints of alcohol because I'll go through the pint every single time. I can't buy fifths because I'll go through the fifth every single time. Like I need to do some things to try to slow down my drinking. But then one of the interesting honest tests with patients is I'll say, you were drinking a bottle of wine. We're going to need you to drop down to a glass of wine. And if they say something to the regards of, well, what's the point of that? Then you have to kind of reflect that back with them and say, maybe we kind of have our answer. In what way? This is not really a foodstuff. This is really, you want to get drunk. Like this is you want the feeling of the alcohol. Right? That's very important. Okay, because moderate drinking is moving to foodstuff. Like it's really that you like wine with dinner, or you want to have a glass of beer at the barbecue or something like that. We can aim for that, but it's going to be really difficult if all you really deep down want is the buzz. It's like I want that, like one glass of wine won't even touch me. Like, well, then you might have an unhealthy relationship with alcohol. Then we might need to revisit full abstinence. All right, patients who decreased excessive alcohol use by 2 zones showed the greatest stability and outcomes. They're interested in changing, encourage a sizable change. They do not necessarily need to do an all or nothing change, but they might need to be pushed to make a big difference. Okay. The topic of alcohol volume and either being protective or harmful, I think this is always very fascinating. This actually extends to some of the public service announcements in the 1990s of saying that a small amount of alcohol is good for your health. And a lot of this connected to the Mediterranean diet. If you have just a glass of wine a night, that's protective for cardio health and blood pressure, things like that. That initial run of the data showed that people who were mild drinkers had longer life expectancy than full abstainers, than people who didn't drink at all. And then they drew the conclusion that some amount of alcohol did help. What they didn't account for was it was a phenomenon called the sick quitter. It basically said that there's a good percentage of folks who fully abstain that are either doing that because of a baseline health issue that is shortening their life. So very severe diabetes would be an example of that. Or somebody who had a really severe alcoholism in their past, had to fully abstain, and maybe through all those years, they went through 8 of their 9 lives. I mean, we don't know. In recent years, this data has been kind of reworked, and there was a large article, it was a 2017 article out of Lancet. It basically said that more alcohol is, in a linear fashion, more bad, and that there might be some low-grade cardiac protective risk with red wine, but that's more than offset by cancer risk. Okay, so when you really look at life expectancy, and that is for women, it's more weighted towards breast cancer, and for men, it's more rated towards throat cancer and colon cancer. So no significant protective associations of occasional or low volume drinking with all-cause mortality, and an increased risk of all-cause mortality for drinkers who drank 25 grams or more. So 25 grams or more is 2.5 drinks, once again, and a significantly increased risk when drinking 45 grams or more per day. So people who are more than 5 drinks a day, they're in I read one study that showed that if you were drinking 5 drinks a day, your life was on average shortened by 2.5 years. I think that it was somewhere between 2.5 and 4 years. And I think the real killer per se, once again, is cancer risk. MAT, I have talked about a little bit of this. We've got naltrexone, the 3 big FDA approved meds to treat alcohol use disorder, and naltrexone, disulfiram, which is antabuse, and then acamprosate. For the most part, I've a little bit killed off acamprosate. There was a very large study, it's called the Combined Study. This was 1,400 patients at 8 sites. It showed a very good value added with naltrexone. And actually, some of the sites, acamprosate was not separating from placebo. So even though this got an FDA approval rating for alcoholism, newer data was showing that this was not panning out. Campbell is also 3 times a day dosing instead of 1 time a day dosing. So it's really not a go-to. We've actually replaced in our treatment, the 2 most common meds we're really using at Cedar to help the drinkers are naltrexone and then gabapentin. So gabapentin is definitely going up the ranks. It is an off-label approach, but in terms of reduction of some of the anxiety and agitation that folks will experience in very early sobriety, their nervous system is worked up. We kind of use a strategy approach. I'll walk through this with patients. We can block you out from your drinking, so that would be antabuse. We could alleviate some of we call post-acute withdrawal. That's where something like gabapentin would play a role, or craving reduction, and that's where we're really talking about naltrexone. So I actually ask patients, I would say, let's say we're really trying to address this. Now keep in mind, these are abstinence approaches, but you would not put antabuse on the table for somebody who's really trying to moderate their drink. Except there's one wild card that you might, okay, and that is somebody who they've done a good job, they drink a little bit, they've cut back their drinking by a sizable amount, and now it's time for the annual trip to the Ozarks with never-ending pontoon boats and gobs of drinking. I have had some patients where you'll take antabuse for the couple days leading up. Would you be okay abstaining entirely on that trip just because it's just so high risk for you and it just doesn't go well? And I've had plenty of patients and they say that's a good idea. I really care about this initiative because the last few years it's been just a nightmare. There's been just a big mess and I just don't want to chance that. Okay. But for the most part, antabuse is in line with an abstinence approach. Some of these other are more kind of you could use gabapentin or naltrexone for both moderation approaches as well. All right, summary ideas. Then I can field the other questions when we talk about this. Moderate alcohol use can be encouraged for heavy drinkers, but a referral to abstinence approaches needs to be available. We would encourage sizable reductions to reach some sort of lasting benefit. So once again, if you have somebody who's a perfect example, if somebody's going through a bottle of wine a night, they might need to do a market drop to maybe a glass of wine a night. So maybe a 70% reduction or 80%. Only very low alcohol use is deemed potentially safe. That's even still debatable. Escalating use beyond 1 drink daily shows escalating health harm. And then the medications we use, we can help people block out alcohol use. We can alleviate symptoms during early change or early abstinence. And we can really try to focus on cravings and craving reduction. So once again, outreach us at Cedar. The truth is, if you want to, you're welcome to even give me a call. If you're interested in outreaching, if you want curbsides, I think we love talking about some of this stuff. We love talking about behavioral strategy, trying to what can be done. We can do something for every patient that we have. It might be heavily harm reduction based approaches, or even just education about what's available if something changes and you want to use more specialty addiction care, or you want to prepare for a full quit attempt from your drinking. And we can design some of these kind of tailored approaches really to everybody. And then I think I'll pause from there, but let me open it up to some questions. And then we'll go ahead.
I have a quick question. So I take care of a lot of LGBTQ patients who often drink or use substances to manage minority stress from all of the chaos that's going out in the world. How does treatment vary for those folks, if at all? And what kind of training do you all have at places like Cedar to make sure those are inclusive spaces?
So Cedar is very good with the whole. We have numerous LGBT providers at Cedar. We have multiple staff who also are LGBT themselves, and definitely LGBT trained. There's a couple of things that some boundaries we would put around treatment that we have done historically. For instance, of any patient who is transitioning, we would want them to be at least either far along in a transitional process, because in terms of where they're at, with a lot of times people come into treatment. We used to be gender-based. We used to have a men's program and a women's program. But we would have patients that they would be in their gender-affirmed space, but not if they were beginning that process. And the point was, in very simple terms, it was just a distraction. It became more about that than about sobriety and really about change. That's actually, that's an interesting overarching concept. We really see with a lot of patients. We have patients who are, and then once again, I would say that that's a subtle resistance to really getting sober. People that are like, well, my main topic is this. And I'm like, that's a topic, but what is crushing your life? The volume of alcohol you're consuming. Okay, so we want to try to make specialty care have something to do with that. We see this also at times where patients will come into treatment and they want to talk about their employment. Like my issue is my employment. And I'm like, well, that is an issue, but we want to keep moving you back to this topic of sobriety and change of your substance. So I've seen that. I have numerous, mostly trans folks I see in my private practice who are on that spectrum. Some folks are very on board with recovery principles, and some are just the same as really most patients of all sorts. They're on the curve of where are they really owning their substance use or not. I think $1 million question also is a little bit of I would say almost like a sigmoidal thing, is how many people are drinking, heavily drinking, moderate, and then alcoholic. And a lot of people will, that understanding where that sigmoidal bump occurs is very important, because it's really about functional status. Are people in a zone that they're really losing, but they might continually say, I'm self-medicating. So that's another way we'll do this. This is not even just with the LGBT community. This is also with people with depression or people with anxiety conditions or all different kinds of things. A lot of times people will fall back and they'll say, oh, I'm self-medicating, I'm self-medicating. At what point are you not? At what point have you developed alcoholism? and kind of understanding that concept. Does that make sense? There, go ahead.
Harm reduction initiatives, how does one go about ordering something like a car device for them to have to breathe into?
They would do that. I mean, we can't. I've never ordered that.
How do you even tell them where to go?
O'Reilly. I mean, you go to like, honestly, I mean, you would go to, Napa Auto Parts or something like that. I mean, because they have very often, most times people are started on that. It is court ordered. That's right. And so, that's kind of what those centers are the ones, anybody who has a device like that, it has to be downloaded, like it has to, it's kind of like a license from the auto parts store. I've rarely had that. And I also believe the only time, once again, that you're gonna get something like that is with a highly invested family member. So like the classic one, a spouse or somebody's parent.
I'm just curious in the literature, under like best possible circumstances, what of the patients who want to drop to levels in terms of their reduction in consumption, what's the highest rate of success with that?
That was what I don't know exactly what the number was. That was what they, what was, yeah, this was the article that talked about, it was statistically significant of lasting. I think it was also the same kind of thing, like of people who, if you did a 2-point drop, it was like at the 3-year mark. How many people kept that going? And then how many people reverted back?
And what was do you recall what the percentage was roughly? I mean, ballpark, was it 20%? Was it 70%?
I think it was on the lower, it's still on the lower side.
Questions in the chat.
Sure, yeah.
Are there any safe medically assisted strategies for pregnant women to maintain sobriety?
I would say gabapentins probably are go-to. It depends also on the stage of the pregnancy, or what trimester with this. We actually have our Kaylin Klee, who a lot of people may know, is our expert for women's and pregnant health plus opioids. There's an opioid recovery plus alcohol recovery. I think naltrexone has some low-grade birth defect risk, but once again, the real standards are a healthy mother for a healthy baby. So like that basically means, let's say I have a mother who went to residential treatment, is now 2 months sober, it feels naltrexone is adding value, and then now gets pregnant. Will I pull the naltrexone? Not necessarily. It depends on how long this woman has fought this fight, and do we think we're trying to do an estimate of, is the naltrexone the make or break? Once again, it's back to this idea of you've got the birth defect risk associated with the naltrexone, okay? But we've got the proven teratogenic risk of the alcohol itself. So for anybody, if she's going into a relapse, so I don't know, these are going to be pretty sophisticated discussions, but for the most part, we're going to take, we have just proven, I call it like the road to death. Like we have, when people are knee deep in their alcoholism, we know that that's a road to death. Another example is antabuse. For anybody, it's for the most part a quasi contraindication of cardiac issues. So if you have a valve replacement or repeated stents, would we not put you on antabuse based on you having the antabuse reaction and then a cardiac event and then a death? But I've had conversations with cardiologists working with my patients, and some of the people will say, you have my blessing to do whatever you need to do. We've proven that this man is dying from his alcoholism. So if antabuse is going to lock him out from drinking, I'm on board. So it's a in-depth calculation and a good conversation, kind of a collaborative conversation with the patient. But it's important to have a sense of what's the real initiative itself, like once again, the idea of like the block-out initiative or the craving reduction initiative.
There's also a question about combining drugs with naltrexone. And so one question about naltrexone with gabapentin. I personally have seen naltrexone with a camphor and I've scratched my head a little bit.
I probably wouldn't do
What
that.
are in there?
I would definitely do it with gabapentin. I mean, those are very, very sensible. That's the most common 1-2 med punch that we have at Cedar. It's probably naltrexone, gabapentin, and then maybe a serotonin medication for like a clinical depression. That's the real straightforward. The only real big one is really, of course, opioids. Naltrexone is just a pure opioid antagonist. You would not want to make, I'm actually surprised that doesn't happen more often, but the idea that somebody is actually on some sort of chronic opioid therapy and then the provider recommends naltrexone, which is a good thing to recommend, but they kind of forget that the person's on chronic opioid therapy.
That too. What's the dose of gabapentin that you're talking about?
Well, that's a good question. So there was one study that looked at placebo versus 900 total daily versus 1800 total daily in one. Okay, so it was 666. So I would say either that's the sweet spot, somewhere between 333 and 666.
Gotcha.
And in terms of reduction in agitation and symptoms and reduction in cravings, which was interesting. That was another finding of that study. We think of naltrexone as the craving med, but maybe gabapentin fills that space slightly too.
Great. That's all the questions from Jeff.
Okay, well, thank you so much. I will be back next week.
Wonderful.
So we're going to talk about stimulants and a strong emphasis on the topic of things like Adderall and Vyvanse, ADHD, and data around practices and approaches to navigate that topic.
Cool.
Okay, thanks, guys.
Yeah. Thanks for coming. Good. 62. Yeah, so when you start gabapentin, you kind of ramp it up a little bit. I mean, I usually, if I'm starting gabapentin,
Everything works.
I would usually not start.
Everything went well?
Yeah.
I would probably I would do like 300.
Okay, so you ramp it up.
Are you in this room again?
Yeah.
I'll be here.
Well, we do have some.
I haven't checked my calendar yet, but
Well, I know we have like the services, I just don't know.
it'd probably be me.
Okay.
Once that exact same setup.
Yeah.
Okay, that works.
Thank you.
Have GABA versus gabapentin is actually a glutamate drug. It's like